very warm welcome to you all to this Western Cape Provincial Parliament Ad Hoc Committee on COVID-19. I'd like to welcome all the members present, as well as the procedural officers. I'd like to welcome the representatives of the Children's Institute from the University of Cape Town, as well as members of the public, other NGOs and media that are joining us this morning. I've received an apology from Honourable Christians, and Honourable Syed will join us at 10:45. Are there any further apologies to be tabled at this stage?
None received, Chair.
Thank you very much. All right, before we get going, I'm just going to run through the rules of engagement for virtual meetings. We please ask that everybody remain on mute to avoid background noises. If any of the members would like to flag a point of order, please do so by using the raise hand function or by typing a message in the chat box. We ask that video and audio be turned off unless you are presenting or posing a question, in which case please do use your camera and of course your microphone so we can hear you, and then to please turn those off once you have concluded your inputs. We ask from the presenters that once you have concluded your presentation to please stop the flighting of the presentation for discussions. And of course our maintenance of order is in accordance with the directives for sittings of the House and meetings of committees by electronic means, which were ATC'd on Friday, the 17th of April, 2020. So with that housekeeping out of the way, today's topic is a topic very close to my heart, children. As a mother to a 3-year-old, I'm keenly aware that the only life he knows is a pandemic life, where masks and sanitizers and temperature checks are normal, where isolation and restrictions on human interactions are normal. And in so many ways, from schooling to socialization, food, safety, nurturing, children's lives have been affected by COVID-19. So today we're very grateful to have the Children's Institute from the University of Cape Town joining us to share their very important research on care and disruptions to care, nutrition, food security, violence and injury, mental health and schooling, and how children have been affected by this devastating pandemic. So before we get going, I'd like to welcome Ms. Laurie Lake, who is a series editor for communication and education specialist from the Children's Institute. I'd like to ask her to introduce the team present here this morning. Good morning.
Good morning. Can I turn my video on? Is that helpful?
Yes, please do. Yes, please do.
Great. So I'd like to start by introducing Shanaz Matthews. Professor Shanaz Matthews is the director of the Children's Institute and leader of the Violence and Injury Brief. And perhaps just to note that this series of briefs was a collaboration that extended beyond the Children's Institute. So we're delighted to have Dr. Heloise Bass, who is an emergency medicine specialist based in the Department of Pediatrics and Child Health at UCT, and who leads the emergency care program at Red Cross Children's Hospital. We're also delighted to have Dr. Thandi Wessels from the University of Stellenbosch, Department of Pediatrics and Child Health, and Thandi is the district pediatrician for Metro East. Yes. So they're going to bring in a health perspective. Nice to see you, Heloise. So delighted to have you here, and sorry to drag you away from the new emergency centre. And then who else do we have in the room? We have Tebeka Mzozoyana, who's a social worker linked to the Schools Improvement Initiative at the University of Cape Town, who's going to share some of her experiences in working with children on the ground, and her colleague, Dr. Patty Silbert, who is the program lead for the Schools Improvement Initiative, again, UCT, Schools Development Unit, and then Professor Mark Tomlinson, who heads up the Institute for Lifelong Development, something along those lines. Mark, you'll have to correct me. And he is a mental health specialist, and global leader in terms of child health and development. So we have delighted to have been able to bring such a strong team together to work on the briefs and to be with you this morning.
Thank you very much, and a very warm welcome to you all. Gosh, what a delegation. We look so forward to engaging with you and learning more about your important work. So we're very grateful for your time and for sharing your insights with the Provincial Parliament. Just by way of background, we are a multi-party ad hoc committee that was established in April 2020 to oversee the work of government as it responds to the pandemic. But we're also looking at the pandemic in a more holistic way. And it's exactly presentations like these that help us to better understand the effects and the impact of the pandemic on society in general, and today, especially on children, one of our most valued members of society. For members, what we're going to do is we're going to have 3 presentations now. We will then pause to have a Q&A session on those presentations for about 30 minutes. We will then have the remaining 3 presentations and then again a Q&A thereafter. And once that's concluded, we'll do some committee admin. So with that said, please be welcome, and I'll hand over directly to Ms. Lake. Thank you so much.
Thank you. So I wanted to just start by saying a few words of introduction. So we sort of midway through the pandemic were invited by the Michael and Susan Dull Foundation and the Children's Hospital Trust to coordinate the development of a series of advocacy briefs to raise awareness of the impact of COVID-19 on children, but also to call on both government and civil society to really prioritise children in our response and recovery plans. So we all know that early on in the pandemic, we were incredibly grateful to know that children had been spared the worst of infection. But as government's efforts kicked in to curb the spread of the virus, the associated lockdown and economic recession have really deepened levels of poverty, hunger and inequality in the country, and intensified pressures and the threat of violence within the home, whilst at the same time limiting women and children's access to schools, healthcare, early childhood development and social services. So incredibly disruptive, absolutely unprecedented, and certainly as a country, both government and civil society really rose to the challenge of trying to find ways to live with and curb the spread of the disease. But we also know that children are particularly vulnerable both to the immediate shock and the enduring impacts of COVID-19. And this is particularly the case during the sensitive and rapid periods of development, such as the first 1,000 days of life, so from pregnancy through to the time when a child turns 2, and then again in adolescence, when exposure to hunger, violence and adversity can really cause irreparable harm to children's immune systems, their developing bodies and brains, and as a result to their long-term education and employment prospects. So it's important to care about children, not just in terms of children today, but in terms of those long-term and often intergenerational impacts. The series of briefs is really calling on government to put children at the heart of our COVID-19 response and recovery plans. So, as we're starting to come out of the Omicron wave and we're starting to think of a new regaining our lives, we've also got to realize that we need to continue to put children first when we're thinking about recovery. The briefs document the impact of the pandemic on children and children's services, and they also aim to identify opportunities to strengthen systems, to improve outcomes, and to better support children in future waves of COVID-19, but also in similar crises. And they draw on administrative data from the Western Cape. And we found that even in this relatively well-resourced provinces, children's needs were initially overlooked and sidelined. And we're hoping that the briefs themselves would also provide really useful lessons and a really strong advocacy tool for people working on behalf of children in other provinces. And then just perhaps to conclude by saying that there are 7 domains. So we looked at child-centered COVID care. To what extent were we thinking about children when we put systems in place within the health service to treat and prevent COVID-19? How did it impact on routine health services, food and nutrition, violence and injury, mental health, early childhood development, and education? And so I'm going to stop there and then hand over to Heloise Bass, who will share the findings on children and COVID-19 care.
Good morning to our esteemed guests. I hope that you can now see my screen and hear me clearly.
We can, thank you.
Thank you very much. So this talk sets to trace the impact of COVID-19 on children in the Western Cape and to identify opportunities to strengthen services and garner support of the honourable parliamentarians for children during the COVID-19 pandemic and even future crises. Much of this information is taken directly from one of the 8-part series of advocacy briefs, and as such is a concerted team effort, of whom I will only name Laurie Lake and Maylene Shung King as the pivotal drivers, though the many others contributing to all the briefs and to all of the people providing clinical care in all the facilities will be our unsung heroes. Please go to YouTube and listen to the media brief and get your own copy of the series. Okay, so first of all, in the first year of the pandemic, there were over 284,000 cases of COVID-19 in the Western Cape, and of these, 12,300 were children. Of these, 1,500 were admitted to hospital, and sadly, 59 children died of COVID-19 in the first wave. Fast forwarding almost 2 years along and 4 waves later, under the shadow of the pandemic, there now have been over 658,000 cases of COVID-19 in the Western Cape, and of these, 46,455 of these were children under the age of 18. And a total of 3,924 children have been admitted to hospital, and 123 children died since the beginning of the pandemic. However, thousands more children have been affected by the illness, loss of income, and death of family members, with 5 million children around the world estimated to have lost a primary caregiver from March 2020 to date. As the health services prepared for the first wave, children's needs were sidelined. Resources were diverted from pediatrics to adult COVID care, and concerns around infection led to the separation of infants and children from their much-needed family support. And now there was a real risk of deaths occurring from other non-COVID-19 related and preventable causes. Over time, the health specialists advocated for more child and family-centered approach to the contact tracing, the care of neonates and children in hospital, in order to minimize their stress and to improve their outcomes. Pediatric guidelines were developed and synced with the national guidelines, and a local pediatric COVID-19 working group was set up and initially met weekly. We need to ask ourselves a few questions, but before that, I would just like to show you our efforts at turning that awful COVID-19 testing tent into something that was child-friendly, with beautiful murals and adding some warmth to the icy cold room. So the first question, did the health system provide child-centered COVID-19 care? Not really. Everything was adult-focused. Quarantine and isolation facilities were set up with adults in mind. with children over 12 put into single rooms without much support or supervision. The intermediate care facilities for children were not an option, as the risk of super spreading to other vulnerable children and staff was quite real. Social workers worked feverishly and were reluctant to place children without the testing, and so the primary healthcare facilities had to be capacitated to do this. And all hospitals with pediatric wards made a plan. Did the health system provide child-centered COVID-19 care to newborns and their mothers? Available research at the time indicated that transmission to newborns was quite rare. So general preventative measures with screening and targeted testing were put in place. Spacing within the kangaroo mother care rooms was controlled. Breastfeeding, however, continued to be promoted, and COVID-19 positive mothers and babies were kept together if both were well. And those COVID-19 exposed and positive babies were managed in single closed incubators. Their mothers had 24/7 access, and video calls were encouraged for fathers who sadly were excluded. And then one of the more tangible impacts on children was the appearance of a condition known as the COVID-19 associated multi-system inflammatory syndrome, otherwise known as MIS-C. In the first 10 months of the pandemic, Red Cross and Tygerberg Children's Hospitals saw about 70 children with MIS-C, of whom 40% required ICU admission and blood pressure support, a serious condition. It mimics another condition that we know called Kawasaki, but the children with MIS-C are generally more ill, with quite severe heart muscle involvement, gastrointestinal involvement, brain and kidney involvement. They frequently require intensive care and expensive special investigations and treatment, which is only available at tertiary centers. Hereby, the pandemic is exposing local and global inequities. Much hype has been made. It actually is quite uncommon. There are about 22 cases per 100,000 infected children. However, it is a very serious and very expensive condition to treat, and ongoing awareness continues to be needed. The care and protection of children whose caregivers have been hospitalized has been a huge concern. Apart from their general day-to-day care and needs, they face huge anxiety and fear. We know that children are profoundly affected when their caregivers fall ill or get admitted or go into Q&I, or worse still, die. They need intensive support during this period of anxiety, separation, and bereavement. Therefore, we need to put systems in place to ask if there are children in need of support when adults are admitted with COVID-19. Children need information in child-friendly formats on COVID-19 prevention, the signs and symptoms of disease, the treatments available, and the prognosis. And they need adults to take time to listen to their fears and concerns and to answer their questions. So one such form of ongoing dialogues with children has been successfully achieved by the RX Radio. It is the only children's radio station led by children, providing a safe platform for them to talk. So one of the dialogues from children who reflected on this impact of this terrible virus, let me read at the top. Coronavirus sometimes makes me feel scared, because sometimes I can cough or have heavy breathing, and I'm not sure if it's coronavirus or just my asthma. And if something like that has to happen to me, it would affect my chest even more, because it will give me heavy breathing. And sometimes when I get too frightened, then my chest sometimes turns tight, and it could affect my chest even more. One positive note was the appointment of Christina Nondo as the Western Cape Children's Commissioner to promote, protect, and support the rights of young people with their participation. What about long COVID? Does it exist in children? Emerging data shows that actually, yes, some children, as with adults with long COVID, experience similar lingering symptoms weeks to months after infection, including fatigue or difficulty sleeping, muscle and joint pain, headache and inability to concentrate, persistent nasal congestion, and weight loss. Some of you will know exactly what I mean by this. One Italian study showed that more than 40% of children in one study had at least one problem more than 2 months after infection. It is thought to be increasingly impactful on the ability of affected individuals to bounce back to work or school. And we do need to raise awareness with families and colleagues as ongoing supportive care is needed. So, what are our key lessons and recommendations? 1, to provide access to child-friendly information and safe platforms to talk about experiences and express concerns. 2, provide care and protection to children when their caregivers are hospitalized with COVID-19. 3, each child admitted to hospital needs their bedside caregiver, even though they may initially deny that need. Keep mother and infant and young child dyads together and continue to promote breastfeeding. 5, advocate for more affordable medicines and diagnostic tests for children. 6, protect resources and essential non-COVID-19 pediatric care. And 7, ensure that there are child health reps supported by clinical government teams to guide on the national and provincial command structures. Children are particularly vulnerable. Their healthcare, their development, and quality of life are time sensitive and cannot be postponed till after COVID-19. And childhood sounds out today. My name is today. Please pay attention to me. To end, I have a ray of sunshine amidst this pandemic. A brand new child-friendly EC for children at Red Cross Children's Hospital was opened on the 24th of February by the Honourable Western Cape Minister of Health, Dr. Noma French Mbombo. It was attended by Western Cape Premier Alan Windey and the Head of Health, Dr. Keith Clutty, and COO, Dr. Sadiq Karim. The funds were raised by the public and by through our Children's Hospital Trust. Thank you very much for listening.
Thank you kindly. Ms. Lake, are we going to proceed to the next presentation now?
Yes, we're going to run the 3 presentations in a row, so handing over to Thandi Vessels.
Thank you very much.
Hi, everybody. I'm just checking. Can you see my screen?
We can. Thank you very much.
Excellent. Let me just go to presenter mode. There we go.
Great. Thank you.
All right. So thanks, Eloise, for that wonderful introduction. I'm going to talk about the disruption to routine health services. And I've also was one of a team of clinicians that are from the metro hospitals as well as some rural hospitals, some members from our provincial health impact assessment department, as well as Laurie and Maylene. So maintaining routine health services for children is actually is essential to ensure overall health, and also to make sure that the gains that we've made over the past few years are not lost. One of those gains is the decrease in under 5 mortality, which is down to about 32 per 1,000 live births. There's been a great appreciation of need to invest early and across the life course. Specifically, we look at the nurturing care framework, as well as in the Western Cape, we've had our first 1,000-day strategy, which was adopted as part of an apex priority within the Department of the Premier. COVID-19 had an uneven impact on child health services in the province. We saw relatively few cases in children, but the health system response was not even. Maternal and child health services were deemed essential, but because of the high burden of adult disease, it was inevitable that resources were reallocated. There was a de-escalation of services as well as cancellation of outpatient visits, as well as elective surgeries or procedures. Looking at the primary healthcare indicators for the province, there was a 23% decrease in primary healthcare visits from 2019 to 2020. And we saw almost 500,000 fewer children in 2020 compared to 2019, with a dramatic drop during the hard lockdown and visits failing to rebound to pre-pandemic levels. If we think about this in a different way, it can also equate to almost 500,000 lost opportunities to treat infection, to monitor growth, to treat and screen for illnesses such as TB and HIV. This next slide looks specifically at other PHC indicators such as HIV, TB, as well as our birthing rates. And you can see that the number of births remained relatively stable, but there was a 57% increase in infants testing positive for HIV at 10 weeks. The numbers are small. It went from 28 to 44, but this was only looking at data in 2020, and I can confirm that those numbers have increased in 2021. The number of children under the age of 15 on ARVs also dropped by about 3%, as well as the number of children who were started on antiretroviral therapy. And we also saw more children defaulting treatment. Subsequently, in clinical practice, we've actually been seeing the knock-on effects of this. We are seeing children presenting with severe and complicated disease. For the first time since the massive ARV rollout, we are actually seeing children with features of stage 4 HIV. This is very alarming. If we look at the screening numbers for tuberculosis, there was a drop in this as well as in the number of children who are on INH prophylactic therapy, as well as the number of new cases starting on treatment. So not surprisingly, with the drop in children being seen, we also see the same drop in HIV testing, as well as those testing positive. If we look at the numbers of children who tested positive between the ages of 18 months and 5 years. What was the impact on hospital services? So we know internationally, as Eloise mentioned, there was a decrease in admissions. This was also seen here, and during 2020, there were almost 15,000 fewer admissions to our hospitals in the Western Cape. That's a lot of admissions. So we think this was due to the decrease in acute admissions as well as the de-escalation of services. So this resulted in children not receiving certain important life-sustaining, life-maintaining, and palliative care, as well as surgeries. For example, ENT surgeries or the placement of PEG tubes, which is quite important for children with swallowing difficulties. These have all had a prolonged impact on the health and well-being of the child, since it has lifelong effects. We also saw a 36% decrease in pneumonia admissions and a 28% decrease in diarrhea admissions. And during the surge, which is generally it runs from November to about May, June, but during April to June in 2020, there was a 72% decrease in pneumonia admissions. And this, we think, could in part be due to the lockdown restrictions. So social distancing and hand washing, so those were good effects, but also people not accessing care. If we look at our current numbers in 2022, they are higher than pre-COVID levels. Of note, also right at the bottom, is that the mental health visits for children under 18 years decreased from the 2019 to 2020 period. And pre-pandemic, this number was already not optimal, with adolescents finding it really difficult to seek help and staying in care. What was the impact on our hospital services? So our pediatric hospital beds, some of them were reallocated to adult COVID-19 care, and we still do not have the same number of beds as we had pre-pandemic. We've had neonatal bed pressures that have been an ongoing problem over the last 10 years. The services do not match our population. We don't have a birthing site in the East River drainage area. So there's inequity between the different health districts within the metro, as well as the province, as well as inequities within some of the health districts. There's a severe shortage of high care beds for critically ill children, and this has been ongoing pre-pandemic. Our adolescent service at Groote Schuur Hospital, was closed and then moved to Red Cross. And currently the service is still there, and it seems that it will remain there. At one of our hospitals in the Eastern Sub-District, our pediatric beds were closed. They've only reopened half, and now they require that we motivate to have more of them opened. And those extra beds are being used for adult patients. We also had the closure of Soonstraal Hospital in Paarl. It was a pediatric TB hospital, and it was converted into a COVID-19 field hospital. And we understand why this was done. But, you know, the question is, what happened to those children? Children that are admitted to a TB hospital usually have complicated disease, and they have many problems, social problems, for which hinder the ability to be cared for at home. Intermediate care was not really an issue in terms of children with COVID needing intermediate care, but we do need step-down care for children with non-COVID related illnesses. And because of the pandemic, there is no funding. We also saw a de-escalation of services, and this really impacted children with long-term health conditions. Long-term health conditions are things like asthma, epilepsy, children who required surgery for congenital heart disease, hernias, dental extractions. None of these happened during the pandemic, and we are now seeing the after effects of this. Children with disabilities have suffered. There hasn't been any access to palliative surgeries. We still are having major backlogs, and our allied health services such as occupational therapy, physiotherapy and speech therapy services were stopped in the district, and those teams were moved to the vaccination sites. So some of these children do not have mobility assistive devices such as buggies that will help them move around. And some of them have actually suffered regression in function because they haven't had rehab services. So what was the impact on under 5 mortality? So although we've had fewer admissions, the under 5 mortality, the in-hospital mortality rate for children in 2020 was higher than in 2019. So for pneumonia, that went up from 2 to 2.8 deaths per thousand. And for diarrhea, the in-hospital mortality rate went up from 1.8 to 3 deaths per thousand. And this could mean that even though fewer children were admitted, those who were presented late with more severe infection, and we think this could have been due to traveling restrictions as well as parents delaying seeking care for various reasons, and one of them could be fears of contracting COVID-19 at healthcare facilities. And as I mentioned before, we are still seeing patients who are presenting with advanced disease, children with severe acute malnutrition, advanced with disseminated and complicated tuberculosis, as well as severe HIV. What is the impact on adolescent health? So school-based support groups for young mothers were started in the Eastern Sub-District in 2018. And these groups were called the First 1,000 Day groups, and they provide emotional support, they promote nurturing care for children, and it helps moms stay in school, prevents further pregnancies, and helps with breastfeeding as well as immunization rates. Yet, during the pandemic, the number of new pregnant moms at one of the schools at which these programs were increased dramatically, with about 20 pregnancies during lockdown. So subsequently to this, we have been looking at establishing wellness hubs, and one of our partner NPOs in the area started a wellness hub, and since then we have seen lots more young adolescents accessing contraception at these wellness hubs. So we've also had reports of teenagers with increased anxiety and suicidal ideation, and in 2021 we saw an increase in completed suicides, sadly, and this was, directly related to the pandemic. So we therefore really need to make greater efforts to improve access to adolescent-friendly healthcare during pandemics such as COVID-19, including access to contraception and mental health services. Why is leadership and advocacy important for child health? I'll go through a few reasons. So provincial leadership and guidance were actually quite essential in coordinating the COVID-19 response and advocating for child health services. But this also needed advocacy from clinicians in order to get this leadership going. Some examples of this was a multidisciplinary provincial pediatric COVID-19 working group, which was established to coordinate efforts and share knowledge. We reported on indicators, did literature reviews, helped with guideline development, as well as clinical service planning and advocacy activities. A provincial task team was then also appointed to develop a maternal and child health services response plan, and this was multifaceted, and it included proper infection prevention and control. It broadened the focus beyond just direct COVID-19 care, but also looking at strengthening routine health services and addressing impacts of COVID, such as hunger, food insecurity, and violence. Yet, despite getting the green light to preserve child health services, we still do not have access to all the in-hospital beds as before. Not all the activities have been restarted in communities, and in schools, children haven't been assessed for special provisions over the last 2 years. And I'll use examples of children that I see in my clinics, and those are children who are on the autistic spectrum and those with learning difficulties. And it's essentially a loss. 2 years that have been lost. Another good, or shall I say, another positive impact of advocacy was getting our immunizations back on track. And we had a Metro Health District Forum that was repurposed to address the impact of COVID-19, but we continued to monitor the essential child health services, and this drove an intensive effort to improve immunization coverage across all the districts, and we actually ended up having an increase in our immunization coverage which was higher than pre-pandemic levels. So this is really a positive, and we used a range of innovative communication strategies, including radio, SMS, community health worker visits, and so forth. And finally, my last slide, the recommendations. Importantly, we need the best interest of the child should guide every facet of the health system's response to children, especially in the context of a crisis or a pandemic. Leadership and advocacy for a child is needed at every level of the healthcare system to protect, sustain, and rebuild child health services. We need to strengthen surveillance systems to identify children at risk and optimize the use of community health workers in maternal and child health services to reach out and bridge the gap between communities and health services. And I'd like to end off with a poem by Gabriela Mistral. Many things we need can wait. The child cannot. Now is the time his bones are formed, his mind developed. To him we cannot say tomorrow. His name is today. Thank you.
Thanks, Jen. Okay, I'm going to switch our attention to nutrition and food security. And once again, this was a collaborative effort led by Professor Michael Hendricks, who is with us today to answer questions from a nutrition and health systems perspective, together with colleagues in the health system and Andrew Boraine from the Western Cape Food Forum. So we know that even prior to COVID-19, 1 in 10 children in South Africa lived in households where a child went hungry, sometimes, often, or always, because there wasn't enough food. And 1 in 3 children lived below the food poverty line of, well, it's estimated that it's going to be increased to 745 Rand in 2022, but of 624 Rand back in 2021. And that's equivalent to 21 Rand a day. And there's very little that you can buy with 21 Rand a day. And the food poverty line is intended to meet a person's daily energy requirements. That's not necessarily their full nutritional requirements in terms of micronutrients and dietary diversity. And there's certainly not enough money to cover other living expenses such as clothing, transport, electricity, school uniforms, school fees, etc. So of deep concern, the very, very high levels of child poverty in our country. So it's not surprising that we are faced with what's called the double burden of malnutrition. 1 in 4 young children in South Africa are stunted or short for age. And they're not only physically stunted, not only is their physical growth stunted, but also their cognitive development, which has a profound impact on their ability to learn, their educational outcomes, and their employment prospects later in life. In addition, 1 in 8 young children in South Africa are overweight or obese. And this is double the global average, and overweight and obesity rates increase rapidly across the life course, affecting 27% of adolescent girls and close to 2 out of 3 adult women, helping to fuel an epidemic of non-communicable diseases in adulthood, such as diabetes and heart disease. So this burden of undernutrition and overnutrition that starts very early in childhood has an impact right the way across the life course and carries huge costs, not only for individual children and their families, but also for us as a society. We also know that 50%, close to 50% of all child deaths in hospital are associated with either moderate or severe acute malnutrition. So malnutrition is a challenge to children's ability to survive and to thrive and reach their full potential. So what was the impact of COVID-19? In the early months of hard lockdown, we know that nearly 50% of households ran out of money to buy food. And child hunger increased by about 50% from pre-pandemic levels and remained unacceptably high, with 1 in 7 households reporting that a child went hungry at the end of the NIDSCRAM survey in May 2021. This was accompanied by the disruption of routine health services, which made it that much harder to identify and support children at risk of acute malnutrition. And perhaps this explains why we saw a decrease in the incidence of severe and acute malnutrition cases presenting to facilities and in hospitals in the Western Cape. So despite the rise in child hunger, we saw fewer children entering the healthcare system. But that doesn't mean that there wasn't an increase in malnutrition and stunting rates at community level. That was simply not reflected in our administrative data because the cases were not seen, not recorded, nor were they treated. And therefore, it's of grave concern that we're starting to see the impacts of protracted hunger in the increase in more severe forms of acute malnutrition in our health facilities, kicking in late in 2021 and 2022. We know that the Child Support Grant has played a really vital role in helping to mitigate the effects of poverty and hunger in the country. And it supports 13 million children, helping to improve health and nutrition outcomes. And yet, it's not enough to take the edge. Well, it's not enough to address malnutrition. As you can see, it remains well below the food poverty line of 624 Rand a month, and even further below the upper bound poverty line, which would be sufficient to meet both the nutritional needs of the child and their other basic living expenses. So we are expecting child hunger to intensify in the coming months due to a decrease in the real value of the Child Support Grant, which has failed to keep pace with food price inflation and continues to fall way below the food poverty line. We're also concerned about the ways in which food insecurity at a household level is impacting on food choices within the home. So caregivers are feeding children the same food every day, starch every day, starch every day. People are not okay. It's not healthy to eat starch every day. We want to eat right, but we don't have a choice. We can only buy the basic foods now, and we buy the same things over and over again. We have no choice. We have to survive. But these kinds of choices, the push to buy foods that are high in energy but low in nutrients, are likely to fuel an increase in stunting, micronutrient deficiencies, and overweight and obesity. So it's important to recognize how malnutrition casts a really long shadow across the life course. In the 2020 gauge, we talked about it as a form of slow violence that occurs gradually and out of sight, a violence of delayed destruction that eats away at the developing body and brain, and is typically not viewed as violence at all, and that is helping to fuel an intergenerational cycle of poverty and disadvantage. So what are the specific recommendations? The first is to increase the Child Support Grant to the food poverty line and to address barriers to early uptake of the Child Support Grant in the first year of life, where we're looking at about 50% of children in poor households in the Western Cape not currently accessing the CSG. We also need to use taxes, subsidies, and price controls to limit food price inflation and to make a healthy food basket more affordable. We need to sustain and enhance the quality of feeding through ECD programs and schools, and the Western Cape is certainly to be lauded for its efforts to maintain the NSMP in very, very difficult circumstances. And we need to strengthen surveillance and referral systems to identify and support particularly very young children who are at greatest risk of severe and acute malnutrition. And then we need to take care that the measures we introduce to alleviate hunger, such as our school meals and food parcels, are nutritionally balanced so that they do not increase the burden of overnutrition and micronutrient deficiencies. And finally, local governments need to explore innovative ways of using licensing and zoning regulations to limit the number of unhealthy food outlets and to ensure a more equitable spatial distribution of healthy food retailers so that all children can access a healthy food environment rather than living in a food desert with no access to affordable healthy foods. So thank you very much. That's it from me. And we'd welcome questions from the committee.
Great. Thank you very much for those presentations. Some very important information for us to take note of. I'm sure members have quite a number of questions. We will proceed in the usual way by political party. I will give each party 2 minutes to pose their questions. If I could ask the presenters if you just take note of the questions coming your way, and then we will have the answers once all parties have posed their questions. Let me just get my timer out. All right. Okay. Let's start with the DA. Are there any questions from the DA?
Indeed.
Thank you. Honourable van der Westhuizen, over to you.
Thank you very much, Chairperson, and thank you very much to the presenters. And thank you for not only highlighting the damages done and the problems, but also for some of the suggestions that you've already made. This is really valuable to us. Now, the first one is then linking on to this. What lessons do you believe should we take from your report and your summary of the situation and would you like perhaps to cover those areas where you have not yet made some suggestions? Then secondly, it seems that some children have really suffered a lot more than others, and how can we identify those that have suffered and that are still in need of remedial action? How can we identify them, and what can we do at this point in time going forward? And then lastly, thank you very much in terms of your reference to the school feeding schemes. Really, I think if you would like to just expand on that and just, say, I do know that the Western Cape Minister of Education was at one stage even taken on by the Human Rights Commission for opening up school feeding schemes. Your response to that, please. Thank you, Chair.
Thank you, Honourable van der Westhuizen. There's still 30 seconds, so I'm going to jump in with those 30 seconds. I just want to return us to breastfeeding. I read a limited study that showed that breast milk can transfer antibodies against COVID-19 if the mother had been infected with COVID, but also if the mother had been vaccinated. I was just wondering if there'd been any local studies showing whether breast milk can help protect small children and babies from maybe more severe COVID outcomes. Okay, that then concludes the DA's time. I'll now recognise the ANC. Are there any questions from the ANC?
Thank you, Chairperson.
Thank you, Honourable Vogel. Off you go.
Thank you so much, Chair. Good morning, everyone. Chair, I also welcome the different presentations from the Institute. I must say I was really touched today with the presentations, because normally we think that we are doing things the right way and we are covering everything. But when we engage with institutions like these, we realize that we actually are failing our people, of our children. And if we look at the word children, that's our leaders of tomorrow. But nevertheless, we are really grateful for the role that these institutions play in our society. And I also appreciate their recommendations. Chair, I do have some questions. I just want to check on slide 3. Of the 123 children that died, do we know, or do they know, which variant and how many had underlying illnesses, as well as their ages? And how is the situation like at schools now, that schools are operating in full capacity? Then, Chair, with regards to the estimated number of children that lost primary caregivers globally, do we have an estimated for South Africa and the Western Cape? And also, what is the number of child-headed households that were created by COVID-19? Then, Chair, I want to know on slide 12, what support was given to children when parents were hospitalized or died? And if you come to the disruption to routine health services, what is the cause behind the rising mortalities rate in the two categories, and what was the overall increase on child mortality in the province? Then lastly, Chair, if they can elaborate on the role that community health workers can play in maternal and child health. Thank you. I will park that, Chair.
Thank you, Honourable Van Wickel. We now move then to the EFF. Are there any questions from the EFF?
Yes, thanks, Chair.
Thank you, Honourable Pleho. Off you go. You've got 2 minutes.
Okay, thanks, Chairperson. On the issue of the children that were subjected to IMS services, what I wanted to check is that were they directly infected, or were they just affected by the fact that some of their guardians and parents were maybe infected by COVID? So I just wanted to understand the direct impact to the kids, if they were the ones that had to be subjected to hospital for COVID-related illnesses. And then there is a report that children that were on ARVs, they have dropped from 743 to 647. And also the TB affected children also dropped in terms of interaction with the health system. So what I wanted to check is how do we recover that? How do we see to it that, especially those that were on our data system, that we knew who they were and where to find them? What have we done to ensure that we recover that? And then the issue of the closure of the pediatric hospital in Paarl had a direct impact on how the children get assisted. That what would be the turnaround kind of strategy? Because if we would directly impact on children and do not do anything in order to assist them to recover under the circumstances, then it would mean that we are dealing with the youth on the future of South Africa from a very early age negatively. So what is a turnaround strategy as well there, that to ensure that hospital would be brought back in functionality and it serves the children as expected? Thanks very much, Chair.
Thank you, Honourable Pleho. We now move then to the Freedom Front Plus. Honourable Marie, do you have any questions?
Yes, I certainly have, but I'm so depressed after having heard what was said that I'm shocked. I want to ask, are we playing God here when we close children facilities and give the beds to adult beds, make the children's beds in hospital beds for adults? Are we saying a child of 5 or under 5 that is very ill has less need for a bed than a person over 60, because I know we are very concerned about the over 60s. A nation depends on the youth and the new children that's born. And we can't play God. So I want to know, you have a multidisciplinary team that has been established now. From the health department is included in there. I would like to know, are these part of their recommendations? Is the provincial health department part of this plan to have less beds for children and more for adults? And why? And then I would like to know the HIV and the children that still get HIV transferred from mother to child. Do you still give mothers nevirapine and AZT cocktails to stop their babies from getting HIV, or did you stop that as well? And then I would like to know that you have a long list of, we need to do this, we need to do that. This multidisciplinary team, have they agreed with you that we can expect to see in our 22 budget still to be delivered, that there would have been provision made for all the needs list you have shown us here? Those people suffering from long COVID, who need bedside caregivers, who need access to a child-friendly environment, and affordable medicine for children. Did you make a provision for this? Or is it going to be, there's no money, so no matter what your recommendations are, we can't help you? Are our children at risk because of bungling, that we put the needs of children lower on the priority list than the needs of adults? Thank you.
Thank you, Honourable Marais. I see Honourable Brincase is joining us, although he's not a member. We'll give him an opportunity. Honourable Brincase, would you like to pose a question quickly?
Thank you very much, Chief. At the moment, I don't have a question, but yes, sir, thank you very much. I'm covered at the moment. Thank you.
All right. Thank you very much. That then concludes the round of questions. Can I hand back to you, Ms. Lake, to divvy out the questions and for responses, please?
Thanks, Honourable Wenger. So the first question was, some children suffer more than others. So how do we go about identifying them? And I'm just wondering if Thandi Wessels could respond to that question.
Hi. All right, so I think how we go about identifying them is really, people need to become aware that they need to access services. So some of the problems we've had is with every wave. Unfortunately, as soon as the numbers increase, we have to cut back on outpatient services because we have the same pool of staff. So there's the same pool of staff that's doing everything. There aren't really many more bodies available. So I think one of the things would be that we do not cut any services during the forthcoming waves, that we try and ring fence funding for child health, and that child health doesn't suffer. So because what does happen inevitably is, if you are, I think maybe I'm also answering a question that's later on about, why do children need fewer beds than adults? It's a difficult situation when you are faced with people dying. And I think this is what the difficulty has been in the health sector, that when you are faced with somebody who's dying, that's who you will try and save in front of you. But we, as a child health group, have been advocating that we need to ring fence services for child health. So we need to use community health workers to go and collect and do go and do home visits, and not just deliver medication for adults, but also do do visits for maternal and child health to try and find people at risk. And then we also need to be, I think, a lot more vocal about in our communication campaigns about ensuring that it's safe for people to come and access services. Yeah, so I think we need to do that. So we were using radio and we were encouraging people to come for routine services, but you know, it's difficult to when people are afraid. So we need to look at those issues as well. Thanks, Laurie.
Thanks, Thandi. If I could hand over to Michael just to respond to the questions. There were two questions. One was around school feeding and the second was around breastfeeding. And I'm just wondering if you're able to respond to those two, Michael.
Yeah, so the question around breastfeeding was, are children protected from COVID-19? Well, certainly I think that there's no clear evidence in terms of a higher risk of COVID-19, the vertical transmission of COVID-19 through breastfeeding. And we know that breastfeeding is in general protective. It protects children against mortality. It protects them from respiratory infections, from diarrheal disease. So there's strong support for continuing breastfeeding, even if the mother is COVID-19 positive. And in terms of the protection of children whose mothers are COVID-19 positive, there is certainly an increase in secretory IgA, which may be protective. Our advice is generally for mothers to continue supporting, to support mothers to continue breastfeeding exclusively, even if they are COVID-19 positive, but taking the necessary precautions. Yeah, so that's just what I would say about breastfeeding. And then the question relating to schools. Can you just so in terms of that question, the opening of, I didn't get the question completely, but it was really around school feeding and the opening of the NSNP in schools. I think that we are obligated to continue supporting the school feeding, and I think that was borne out by the case that was won in the High Court in Gauteng, basically, that where Equal Education took the Minister of Education to court, and it was actually declared that the National School Nutrition Program needs to continue. Yeah, so I think we need to continue it. As far as I know, in terms of the NSCRAM study, I think it's been operational in about, in the last report, in about 60% of schools in the Western Cape. Yeah.
Yeah, and perhaps to acknowledge also that it has been incredibly challenging to maintain programs such as the NSNP when schools were still rotating, and with the opening and closures of schools. So it's not been easy, but absolutely vital to prioritize children. And schools, of course, are another site for identifying children who are in need of care and support, whether that's children who are hungry, children with in need of mental health support, or children who've experienced violence or abuse. So I think we're very grateful that schools are up and running. And similarly, ECD programs are another platform for reaching out to younger children. And then for the youngest children of all, that's really the responsibility of health. And I think what's been very clear in this presentation is the way in which child health services have been stretched thin and perhaps disadvantaged during the pandemic. And we need to make every possible effort, as Thandi says, to ring fence resources for child health, so that they do not get further diverted to adult care. I wondered if Heloise could answer the question around how many children have died, how many had other illnesses, and have we seen sort of changes in the pattern with different variants of COVID, and also what has the impact been of schools opening on infections and hospitalizations. I'm not sure if you're able to respond to some of those questions, Heloise.
Thanks, Laurie. I'm just going to share one slide, if I may.
Yes, please proceed.
Okay, so with regards to the number of children that have died since the start of the COVID-19 pandemic, you can see the spread. This graph shows you the spread since March of 2020. And the dark blue represent children who died in hospital, and the light blue represent children who died out of facility. Now, what is not clear is whether these children died of COVID-19 or with COVID-19. We suspect that many of these children had serious chronic underlying health conditions such as heart disease, congenital heart conditions, chronic lung disease, immune deficiencies, cancer, cerebral palsy, and in fact of the other co-infections like serious TB, severe TB, HIV, and what we have found in the children who have died in hospital, that we have often find other reasons, other infections that could easily also explain the death. So it has never been very clear to us whether they died of or with COVID-19. And we are currently awaiting a full report so that we can inform everybody on why these children died and what were their underlying conditions. In terms of the wave, if you look at the first wave, there were 59 children. That was the representation of the most serious and severe form of the virus. We currently moved through other variants, and with the Omicron, what we saw was many, many, many more children and adults affected. However, deaths were less and admissions were less for children. But we also know that it was not benign because many people still died. I can't answer more than that until the full study has broken down and looked in depth at why these underlying conditions were. Thank you.
Thanks, Heloise. I wanted to respond to the ANC's question about what support was given to children when parents were hospitalized or died. And that was I think in response to the statistics around orphaning. So we know globally that 5 million, an estimated 5 million children will have lost a primary caregiver to COVID in the first year and a half of the pandemic. What's worrying is we do not have clear systems in place to identify what the impact has been on children in South Africa. So one of the strongest recommendations I think coming through from the briefs as a whole is the need to strengthen referral systems between health, education and social development so that we are identifying those children early on. So we're not asking, for example, a routine question when adults are hospitalized with COVID-19. We're not asking, are there children left behind at home who may be in need of care and support? So I think there's a lot of work we need to do to, in a sense, strengthen our response to children in emergency situations, so that we are able to respond proactively, rather than trying to find those children now and to, well, I suppose we still can. We can do that through schools, through ECD programs, through health facilities, and particularly through the use of community health workers who really do extend the reach of health facilities deep into communities. but to track the numbers is going to be really difficult in South Africa. And perhaps just to reassure the ANC representative that the number, the proportion of child-headed households in South Africa are very, very small. It's less than 1% of children living in child-headed households pre-pandemic, and most of those older children and adolescents, and again the majority of those with a parent living elsewhere. So they're not necessarily households with very young children or orphaned children. But whether that situation has changed in the last year and a half is something that we still need to investigate. Tandi, I don't know if you have any thoughts around a turnaround strategy for getting paediatric beds back, or if anyone would like to respond to the Freedom Front's concerns around playing God. So what happens when we start to divert resources from child health to adult care, and how can we in some way influence the provincial budget allocations to ensure that children and children's health are not further shortchanged? Tandi?
Hi, so this is a difficult question. I don't have all the answers. What is the turnaround strategy? So at the moment, we are, as clinicians working in the field of child health, we are all, we have various forums, so in the metro and in the rural, that includes management. And so we have taken these issues to them, and we are trying to slowly address it. I think for us, what we would need is that kind of political will and that ring fencing of resources. That's what we need. I think our managers are quite aware of what the problems are. We present it to them all the time. It is difficult, I think, for everybody when you work in this situation, because you know, the ethics involved are is complicated, especially when it comes to a pandemic. Who needs what more than others? And I, of course, I personally agree that children should never be left behind. We are all passionate about children, and they are the future of our country. So we do need to make sure that people don't forget about children, and that we have a plan and that they're not forgotten. Thanks. And then just one last question around HIV, which was also from the Freedom Front Plus. We still do give PMTCT, it's prevention of mother to child transmission. So mothers receive ARVs, and in fact, as soon as somebody tests positive, they go on ARV treatment. So it's not a cocktail of just PMTCT. It doesn't matter who you are. If you come to clinic, you test positive, you start treatment the same day. So the problem that we've had is that mothers have not come and they've not tested. So they test during delivery. So we start giving ARVs, but of course then those babies are at higher risk of actually contracting HIV. And these are usually people who are the poorer, marginalized. They don't have access. It's the person who will test positive, or the mother that is struggling, generally is struggling in lots of other aspects in her life. Interpersonal violence, gender-based violence, poverty, etc. Thanks.
Thanks, Tandi. And then I just wanted to give Shanaz perhaps an opportunity to reflect on the findings from the child death review, if there's anything that you'd like to add in terms of this first half of the conversation, Shanaz.
Hi, Laurie. Thank you. We're just in the process of collating all our 2021 data, and we certainly, you know, what I can say is that we saw far more deaths in 2021 of children dying from COVID than in 2020. And both in the third and fourth wave. Once we have the data cleaned and available, I'll share it with the pediatric team. But certainly, I think what we need to be clear about is that there's certainly more child deaths that we are seeing, particularly in your younger age children, than what we'd seen in previous waves, in wave 3 and 4, and particularly in your sudden unexpected deaths that's related to COVID pneumonia than what we've seen in previous waves. So that's just a reflection, but I think, once we have all the data clean for 2021, it would be worth for the clinicians to have a look at it.
And that's sharing the findings from the child death review, and that's primarily out of facility child deaths.
Primarily out of facility deaths, yeah. So those would be children that's not dying in hospital, that might be presenting as a dead on arrival, but generally have not been admitted to hospital.
Thanks, Shanaz. Michael, is that a response to Shanaz's point?
Yes, I just want to pick up from what Shanaz mentioned. In relation to malnutrition, for example, severe acute malnutrition, we don't know how many children who die outside the hospital actually have acute malnutrition, whether that's severe or moderate acute malnutrition. And just to keep in mind, and for everyone to know, that about half our deaths in the metro occur outside the hospital. And I just want to pick up on the point, or in response to the two representatives, from the one from the DA and the other one from the ANC, the role of community health workers. I think the DA mentioned, how do we identify children in need of action? And I think it's critical that we actually support community-based services in terms of this. We know, for example, from our child death review data that we have high-risk mothers, and it's important that community health workers are able to engage with those mothers and be able to identify them in the antenatal period and walk them through those through the first 1,000 days. And we are trying to work on that, particularly, or we have been trying to work on that in the metro, trying to actually establish a program whereby we can actually engage community health workers to do this. And I think a lot of support is needed in this regard. Thanks.
Thanks, Michael. I think that's it from our side. So if I can hand over the baton to you, that would be wonderful.
Thank you very much, Ms. Lake. Thanks for responding to those questions. I am mindful of the time, so I'm not going to do a round of follow-up questions now. If there are any follow-up questions, if members would just hold on to them for the Q&A after the last three presentations. If we've got time, then we'll go through those. So I think we then move on to the next presentation, which I believe is surrounding violence and injury. Is that correct?
Yes.
Okay. Are you happy to proceed now, or do you need a quick break?
I've got a bit of a time constraint. I've got to be off the call at 11:25. I've got another call at 11:30. So
okay, let's go ahead.
Okay, shall I go ahead?
Thank you. Over to you. Thank you, Professor Matthews.
Just get my presentation up. Good morning to the members, and as everyone, all the previous presentations prior to this, this is a collaborative effort, and I'd just like to recognize my collaborators, Yolandi Baker, who was then head of Child Safe, Carla Brown, who is the chief social worker at Red Cross Hospital, and Joan Verniekerk, who is an independent social worker. And in this presentation, I'm largely drawing on data from Red Cross Children's Hospital, but also some of the data coming out of other settings across South Africa. I want to draw the members' attention to the fact that in South Africa, we are very aware that violence against women and children are endemic. Community-based studies in South Africa has shown us that 1 in 2 women have experienced physical or sexual IPV in their lifetime, as well as a community-based prevalence study on violence against children has shown us between 35 to 45% of children have experienced violence in the home. And these are really excessive levels of violence comparing it to other countries across Africa. What I want to alert members' attention to is that violence against women and children are inextricably linked. You cannot separate the two. Violence, they share common risk factors such as gender inequality, conflict in the home, as well as alcohol consumption are some of the main risk factors. Similarly, they share common social norms that underpin both forms of violence, for instance, like patriarchy. And both of these then make it possible for IPV, intimate partner violence, as well as violence against children to co-occur within the same household. And what this then leads to is an intergenerational cycling of violence. It's really, really important for us to understand and recognize. What I mean by this is when a child witnesses violence in the home, and I'm talking about just witnessing, for the boy child, it increases his risk of later on becoming a perpetrator of violence both within the home and outside the home. And this is critical for us to remember. Secondly, for girl children experiencing violence in the home, it increases their risk of victimization later on, and it sets them up, both girls and boys, for a trajectory of violence across their life course. We also know that adolescence is a particularly risky period for children, and often it's a period that's not given enough attention. But what is important is that when a child experiences violence early on, what this sets them up is we see poor outcomes in school, we see risk-taking behavior, as well as mental health outcomes that is long-lasting. And I know the next presentation will be focusing on mental health, so I'm not going to be laboring that point. So if we're looking at the impact of COVID-19 in relation to violence and injuries, very early on in the pandemic, gender activists as well as child rights activists raised concerns about how the rising unemployment rate, food insecurity related to this, as well as stresses experienced during the different phases of lockdown increases risks for both violence and injury, particularly in the home. We also know that poverty-related stresses and economic insecurity combined with poor coping strategies such as substance use, particularly prevalent on the Cape Flats in the Western Cape, can lead to increases in both intimate partner violence as well as child maltreatment. And therefore, rapid increases that we saw in unemployment levels during COVID, we felt that it was likely to trigger an increase in both violence against women and children, leaving both women and children often trapped in violent relationships because of the various levels of lockdown that we've been through. So reflecting on some of the data from Red Cross Children's Hospital, what we see here, and this is reflecting just on unintentional injuries, and when I refer to unintentional injuries, I speak to injuries like road traffic accidents, falls, burn injuries in the home. And what we see here is that if we compare 2019 to 2020, there was a 15% decrease in children admitted to Red Cross Hospital for unintentional injuries between the 2 years. And this was largely driven by a large decrease, with over 50% decrease in road traffic injuries during the very hard lockdown periods. And you can see that during lockdown periods of 4 and 5, and it increasing to similar levels once we get to lockdown level 2. So what you're clearly seeing here is children during lockdown level 5 were not going to school, in fact, till lockdown level 3, and the less mobility of children also meant that they were not on the streets, and therefore what we were seeing were less likely injuries due to road traffic injuries. However, what we did see was increases, particularly in lockdown level 5 and 4, were injuries due to burns and falls, particularly of your younger age children, because of being confined to the home and being in very small spaces. It increases risk for this type of injury. For non-accidental injury, which is largely your abuse cases, is less clear. I'm sorry, I'm just recovering from COVID myself, so struggling a bit. There was a 10% increase overall between the 10% decrease in children presenting to Red Cross Hospital with non-accidental injuries between the 2 years. But what I want to say here is that this pattern is less clear and it's a bit messy compared to the previous graph that we saw. And what we did see is that in the hard lockdown periods of level 4 and 5, we certainly saw sharply decreasing during that period, and with it going back to its normal levels during lockdown level 3 and 2. So what it really telling us something about alcohol bans during this period. But I also think, we've got to bear in mind that access to services for children, particularly to social services, were also not optimal during that period. And with Red Cross Hospital being a tertiary facility, often only gets referred, once a child has been seen by a service nearer to home. And therefore, I am very cautious about what these figures are telling us. And similarly, I'm very concerned about what numbers are telling us, because it's not giving us an incredibly clear picture. When the Minister of Police shortly, the first week into lockdown, announced a 37% increase in GBV reporting to SAPS, a month later, the SAPS statistics showed us a different pattern with complaints decreasing. Similarly, our rape crisis statistic shows us 50% decrease in rape and sexual assault cases being reported to rape crisis during the hard lockdown periods. However, Childline, which for some of you who know Childline, is a telephonic service, they saw their numbers increasing significantly during these periods. However, shelters, on the other hand, saw a drop in women and children accessing safety. So all in all, what I am really telling you is that our numbers are not giving us the full picture. This is not common to South Africa, but it is a study done by UNICEF across low and middle income countries show us a very similar pattern, where there was a period of children not being able to access services, and therefore our numbers are not incredibly reliable in terms of telling us what is happening to children during pandemics. But what we do know from qualitative work that I've done and others have done in the Western Cape is that living in confined spaces increase the level of stress in households, fear, with poor mental health outcomes, which can increase the risk for violence, both violence against women and children. Lockdowns, as well as quarantines, also increases day-to-day exposure to perpetrators within the home and can reinforce the abusive tactics that then gets reinforced due to social isolation. What becomes very clear from our qualitative work is that the usual support systems for both women and children, like family and friends or school, were not available during these hard lockdown periods, increasing the risk for violence escalating during this period. What all our qualitative work is showing us that the disruption of social and child protection services were felt by both women and children. It was difficult to access SAPS, the police services, court services, as well as social services. And in fact, I had, one report that's not anecdotal, where a child who was raped by a friend of the families during hard lockdown, the police wouldn't take the complaint because they felt that she was in contravention of the lockdown regulations and wanted to fine her mother for allowing her to be out of the home. And the family wanted to withdraw the case. So this tells us how the ability of children and families to access support services and protection becomes very difficult. And we also know from anecdotal evidence that the following up on Form 22s were also compromised during this period because social workers were not doing home visits, and most contacts were just telephonic, which also didn't provide the protection children needed during that phase. So what are our specific recommendations? So certainly it's really critical that we do prioritize child protection services in our crisis response plans as well. And this has been shown globally from pandemic responses. We in South Africa did not initially designate child protection services as essential services, and this meant that children fell through the cracks and didn't have access to support services at a time when it was crucial. We have to think about establishing local response teams to facilitate access to support services at community level where women and children can access support. We've also got to think about intersectoral collaboration, and this is critical, where strengthening collaboration services between health, education and child protection services is critical at every point of contact to ensure that children are safe. And we can't just rely on a child reporting, because then we're going to miss a number of cases. We certainly see in our patterns that alcohol restriction did make a difference, and it does make a difference to preventing injuries and interpersonal violence, and we've got to think about how we limit the sale. And that's the end of my presentation. So Laurie, over to you.
So if we can just hand over very smoothly and seamlessly to Mark, that would be wonderful. Thanks, Shanaz, for an excellent presentation. Yeah, so over to Mark.
Thanks, Laurie, and yeah, just greetings to all the honourable members and to other people on the call. It's great to be able to talk to you. And so what I'm going to do is talk about the pandemic, child and adolescent mental health and well-being more generally, and something about how we look at the future, and not just about this this pandemic. As many others have done, obviously the brief that we put together was a collaboration with many other people, and I'm going to assume that people on the call have either read the briefs or following this presentation will actually read them. So I'm going to touch on it, but I'm not going to actually go into massive detail about it, because while many things remain the same, I think some things have changed as well. So I'm going to try and touch on that. And I want to start with a slide of someone called Dr. Renee Spitz, who was a psychologist, psychoanalyst, a medical practitioner in the United States in the 1940s. And it was a famous study that he did where he compared children in two hospitals in the United States. And the one was a very well-resourced hospital, and as a result had impeccable infection control. And one of the side effects of that infection control approach was that if children were ill or if their parents were ill, there was a very strict policy of separation of parents, mothers, but usually, and their babies and their young children at all times. Very little contact with nurses, weird little incubator kind of beds, even for older child that stopped the infections. And then he compared those children to a less resourced hospital with fewer staff. They didn't have the resources for all the infection control, and they didn't have enough nurses, and so mothers and caregivers and family members had to care for the infants. And what he found astonishing was that the mortality rate in the well-resourced hospital with this impeccable infection control was massively higher than in the other hospitals. And his study led to the significant change of policies in terms of keeping children, babies separate from parents. And I put the slide in to just remind us of how easily we forget the lessons of the past when we start, in the case of a new pandemic, separating for their benefit children or babies and caregivers. And I want to state that I think public health is always a balancing act and involves a careful weighing up of risks. And I don't think that happened here. I don't think that happened in South Africa, and I don't think that has happened globally. And we only need to see elsewhere about how children, endlessly, again and again, bear the brunt of conflict. The picture on the top left is Michael Kamapi, a South African little boy who drowned in a pit latrine. They bear the brunt of the decisions that are made, and I would suggest that their interests are not put at the center of our policy making and of our approach. So COVID-19, it's not so emergent anymore. It's now been with us for well over 2 years. But I also think that child and adolescent wellness, mental health, mental illness, it's really important. This is not new or emergent, and we've become more aware of it for a variety of reasons, but it's not a new thing. Equally, it's a new crisis, but we know, particularly in South Africa and in sub-Saharan Africa, HIV has been a crisis now for over 30 years. And the care for those with mental illness, for the prevention of mental illness developing, in terms of promoting the conditions that facilitate the good mental health or well-being of children and adolescents. In fact, we have a long-standing care crisis. We're not doing very well in that regard. And in that regard, one of the ways to think about mental health and well-being is to see it on a continuum. And so what we're trying to say in this diagram is that on the one end, we have severe psychosocial disability, severe mental illness. So those are people, whether they're children, adolescents, or adults, who have psychosis, and are often hospitalized or need hospitalization, and that's a very particular severity there. On the other end of the continuum, you've got most people who are mostly psychologically healthy most of the time, mostly unaffected. I suppose you could refer to them as being happy, I suppose. But all of us at various times will start moving across that continuum. So we might dip into a little bit of distress. We might dip into a little bit of have some symptoms of depression, anxiety, or other symptoms. But it, the stress might get a bit high, but we're okay, and then it remits, things improve, and we move back to the left. If we keep moving further to the right, when things start getting worse, we would possibly need to really start thinking about what's the response of the health system, the response of the community, of families, how do we support them? And then obviously, as you then get further across, there can be, new common mental health conditions. And by common mental health, we largely mean, anxiety, depression, the most common mental health conditions that we see. So what about COVID? So perhaps the easiest way to say it is that it's a very mixed picture. So, for example, in some of the early studies in the UK, where a lot of the first studies came up around, started being published around child and adolescent mental health, they found that, for example, there was about 29% of that age group, 18 to 29-year-olds, who had some self-harm or suicidal thoughts. 43% of young people in the UK, and this is in the in 2020, that the first lockdown had made their life worse. But this is very important, is that 25% reported that it made their lives better. So, for example, a hard lockdown when you can't go to school and you're a child who's the victim of extensive bullying, not being at school, and obviously this is, bearing in mind in the UK that children would have had access to digital learning, but they actually, that would have been for them, perhaps an improvement of their lives. Interestingly, is global suicide rates in the last 2 years for children and adolescents as well as for adults have either remained stable or in fact gone down, which again is interesting. This is an interesting paper that was published last week, and this is a longitudinal study also from the UK where they looked at children and adolescents prior. They had them a cohort of children and adolescents in a study. They looked at them prior to the pandemic, and then they again assessed them during the pandemic. And I can share this paper with anyone who's interested. But the interesting thing was they found no increases in mental distress amongst young people. That was the overall finding. But they did find increases in certain subgroups. So, for example, anxiety did increase amongst adolescent girls, for example, but not in adolescent boys. So when you put everyone together in one cohort, that the increase in adolescence amongst adolescent girls sort of disappeared because of the boys being included. So there are these group differences, which I think is this is the way I think we need to start thinking about it. So for some children and some adolescents, there's an immediate response, and it can appear as a crisis, but for many it may not be, and we need to get better. And I liked the question earlier from one of the honourable members about, how do we find out who needs support more than others? And I think that is a key issue. We're busy analysing findings from a longitudinal study that we also happen to have running with a pre-pandemic assessment and a post, and we did find some increases in depression and anxiety amongst 17 to 18-year-olds, but not alcohol use during the COVID-19 pandemic. So again, the picture is mixed and it's complex, and there certainly are increases, but it's not necessarily universal. I think Laurie touched on this. We know, and I think I want to just talk now on the broader contextual and societal issues, which I think are utterly key here. Is we know that what happens from the NIDS CRAM report about the number of learners in South Africa, an additional more than 500,000 who didn't attend school, and this was at the beginning of last year as a result of the pandemic. The implications of that for mental health, for employment, for schooling in the long term is profound. And I think what's happened to some extent in the COVID-19 pandemic is because it has been such a sort of a massive global phenomenon, something that none of us have had to deal with in our lifetimes, something of this magnitude, is it's taken center stage. And I think as all the other speakers have spoken, for a baby, for a child, for an adolescent in South Africa, in fact, COVID-19 is simply one of many other risks that existed before, that exist during, and are absolutely going to continue into the future. So whether it's TB, whether it's substance abuse, whether it's interpersonal violence, violence against women, whether it's the massive rates of inequality and poverty that we have in this country, the racism that exists, the food insecurity, is that the brains of children are being bombarded by massive amounts of risk. And in many ways, what COVID is just yet one more risk amongst many. And I think that's a really important thing to do, because what we don't want is a very short-term response to a COVID, for example, mental health crisis, and then we can sort of rub our hands and say we've done something good now, because the reality is that those caregivers and those children are going to remain in these high-risk situations. And so this is from a report that I was part of producing for UNICEF in 2020. And we try to think of it in terms of what are the pre-existing conditions that all of us on this call know about in South Africa around poverty, violence, health infrastructure, background health, the social conditions, the immediate impacts of COVID, the proximal impacts, because it doesn't just affect the child and the adolescent, it affects the caregiver, for example, their mother, their father. And we know if the mental health of a caregiver is impacted, that has implications on child development independently of whether the mental health of the child has been affected. And I want to think about, very importantly here, is what are the long-term impacts, because that is what we have to really be thinking about. So what do we do? So these are from the brief. The Western Cape Health Department is doing some admirable work in this regard around strengthening of families and relationships, because particularly for younger children, but even in adolescence, that is utterly key. It's those relationships that are going to set the scene. In the context of a shock such as COVID, but again, in terms of HIV, poverty, all these other shocks that happen are going to continue to happen, parents maintaining reliable, predictable routines for their children. Honest communication, for example, about grief. In many communities, the response to the death of a parent, for example, is don't talk about it to the child because you'll remind them of it. So it's good to not talk about it, and the child must just get on with life and they'll be okay. In fact, that's exactly the opposite of what we should all be doing. That actually children need to talk about grief. They need to talk about how they miss their family members. We need to protect and increase investment in child and adolescent mental health services. And you've heard today a lot of talk about how we've lost pediatric beds, we've lost beds in children's hospitals, and it's very easy often to cut investments in child and adolescent mental health services. One of the honourable members spoke about community health workers. I believe community health workers are key in this regard, in terms of offering that front line of support to families. They're going to be the people that see families first, who's struggling with anxiety, depression, violence often, and that's key. And to increase and improve the link between those community health workers and the system. To tackle the structural drivers, we know that so much of this is about endemic poverty, endemic violence, and you've seen, we know the impact of those alcohol bans. We have to do more. And again, the Western Cape Health Department and the Western Cape government, I think, is doing some admirable work in trying to think about taxation, advertising, but we have to do better in that regard. And so the last part of my talk, I want to say is we cannot have an approach to COVID where we have a short-term solution, where we're going to band-aid the problem and feel good about a response, whether it's about mental health or nutrition, that doesn't take a much bigger view. And I would suggest this is a Lancet commission that I was part of from a number of years ago. It came out at the beginning of the pandemic, and that was the timing of it. And it really speaks to how do we create a world that meets the developmental needs of children, and that doesn't make children the last people we think about, that doesn't make children and adolescents have to carry the costs of adult responses to care for adults. And one of the arguments, so we argued, given COVID, given the pandemic, given climate change, given what we know is going to be happening in the future, is we are in the midst of an emergency. And so what do we do? And what we argued in that Lancet Commission is that we require a strategy that puts children and adolescents at the center of not just a pediatric ward, but we made the recommendation, and this is continuing in another iteration organization currently, but how do we put children and adolescents at the center of every single decision we make? And I know this is counterintuitive. I mean, every single decision. So when you build a road, one of the first considerations is that safe for children? Does the road connect communities to health services, to employment opportunities? How do we do that? Because at the moment we do not put children and adolescents, they're probably in many cases not even in the picture, let alone at the center. So we have to see the needs of children and adolescents. Their needs have to become the lens through which decisions are considered and made. And importantly, in the short and long term. One of the benefits of doing this is that it doesn't mean that other people's needs aren't included. If you put children and adolescents' needs and their lens is how you make your decisions, by definition, you're thinking of parents, because a child on its own without a parent, without a family, without a community, a baby will quite literally die. So those decisions involve other people. It's not a shifting and now we're going to neglect other people, but we're saying that we have to put their needs at the center. And if you think about it and you challenge yourself to think in this way, it allows different kinds of policy options. It allows different kinds of approaches, for example, to alcohol advertising and to the impact of alcohol on violence, for example, and violence against women and violence against children. So I'm making a plea that there is a deep concern about mental health and mental health well-being of children and adolescents. And given the impacts societally on employment, on the economy of the COVID pandemic, that's going to get worse. But if we make it only about COVID, if we don't, then it's going to be a short-term band-aid solution. We have to have a paradigm change in how we approach these things. And so my idea is, let's put children and adolescents at the center of everything we do. Thank you.
Thank you, Mark, for a fabulous presentation and really advocating in powerful ways for children at the center. Could I hand over now to Patty and Tembeka to explore how we can use schools as nodes of care and support?
Thank you, Laurie, and good morning to our colleagues and honourable members. I'd like to acknowledge Maylene Shun-King's role in taking the lead on this brief, as well as our co-collaborators and my colleague from UCT Schools Development Unit, Tembeka Mazozoyana, who is a social worker and will be able to respond to some of the questions regarding psychosocial issues in schools. I'd like to begin by framing the schooling context at present. The rotational system.
Sorry, Patty.
Yes.
To interrupt, do you want to share your slides at the same time?
Apologies, I thought I had.
There we go.
So to begin with what we know by now as having had a major impact in the schooling system, the rotational system. So what this has done over 2020 and 2021 was disrupted teachers' abilities to complete the curriculum, negatively affecting learners' mastery of core skills and content knowledge. This we now know is particularly manifest in the younger grades where children learn foundational concepts. With regard to school dropout, this has actually increased almost threefold, with an estimated 750,000 children dropping out of school over the last 2 years. Despite matrics having not been subjected to the rotational system, they did attend classes in full, but due to lockdown, they also lost a substantial amount of contact time, equaling about 35%. The very serious issue of online learning that has become very contentious during this time has amplified socioeconomic divisions, making it very clear that the transition to online learning for our learners in historically disadvantaged contexts was simply not the same as other students in schools. So while 90% of South African households have access to a mobile phone, only 50 to 60 have access to the internet via their mobile phone. And this does not take into account issues such as connectivity, network unreliability, cost of data, etc. So these factors have made it extremely difficult for our learners to have accessed online learning over the last 2 years. Then with regard to the loss of lives amongst teachers, where teachers play a critical role in the lives of the children, particularly in fragile systems of families, the loss of a teacher will have had a tremendous impact on the life of a child. 0.6% of teachers lost their lives between March 20 and May 21, compounding an already fragile schooling system. So overall, what we now know is that learners have fallen up to 70% of a school year behind previous cohorts in language, and up to 106% of a year behind in mathematics. So what we are now clearer in understanding is that it is predicted that learners will be an entire year of learning behind their pre-pandemic peers. So COVID-19 has amplified the deep inequalities in the South African schooling sector, as we've heard it is done in the other sectors. So what we really want to be spotlighting here are the issues that have surfaced beyond the curriculum. What does the school represent in the life of a child? Schools are more than places of learning. These are systems in which young people can access health and care and nutrition through, for example, the Integrated School Health Program, National School Nutrition Program. But furthermore, they are hubs of social interaction and play, which provide structure, routine, and predictability. Once again, these are critical factors where family systems become fragile, where learners come to school through daily interaction with others. They are able to learn relational dynamics, socialization, and thereby are able to start developing a sense of identity, social and emotional development, and of course, self-regulation. So looking at the issues beyond the curriculum, what we have seen particularly in our fairly large cohort of schools in Khayelitsha through our project at UCT, what we have seen and observed is that in many schools, there has been a culture of silence. Silence has been conflated with coping. So where teachers observe that a child is not talking, they're under the illusion really that the child is coping, with the result that children and adolescents are in fact encouraged to suppress their anxiety, their worries, their concerns. This in turn has led to disconnection from self, from their peers and their teachers. And we know that disconnected, disassociated behavior often leads to avoidant, aggressive, and even high-risk behavior. Even before the pandemic, it was estimated that 1 in 3 people would be affected by mental health illness in their lifetime. We know from a schooling perspective that typically these issues manifest in poor academic performance, with the schooling system in many instances being unable, but not necessarily unwilling, to address these issues by helping youngsters to deal with underlying issues of depression and anxiety. What we also know from our own research in the Schools Improvement Initiative is that where in countries around the world, during and after large-scale situational crises, the schools encouraged immediate adult-led discussions, we know that children had measurably better signs of behavioral health as compared with schools where adult-led discussions were avoided. So really, we're wanting to stress the point that the health of a child influences the extent to which they can fully attain their personal and educational potential. The threats posed by the COVID pandemic, and as Prof. Tomlinson has told us, other large-scale situational crises to both the health and education of youth are likely to have devastating long-term impacts on our children and broader society unless we start addressing them and centering the role and voice of the children. So, schools as nodes of support. It is absolutely critical that the educator plays a role here, especially, as I've said already, in the context of fragile family systems. And it is for the educator to understand the importance of their role in creating opportunities for children to feel safe and secure. Given the absence of psychosocial support for the majority of our young South Africans, the school becomes a critical place for mainstreaming and promoting mental health, particularly during periods of adversity. So what does this mean? Well, at the very outset, we believe that our teachers need to have a basic understanding of mental illness. They need to understand the role of trauma in its effects on self-esteem, on behavior and interpersonal relationships. We need to move away from stigmatization and the ignorance of trauma, towards normalizing children's experience associated with mental illness. So what really this is about for us is creating emotional safe spaces. What does this mean? Children need to learn the language of self-expression, the language of vulnerability. They need to be taught skills of emotional literacy so that they understand that their responses and their articulations will not have negative consequences. So in terms of psychosocial support and teacher well-being, I'd like to acknowledge that this is indeed in line with one of the key recommendations of the recently held basic education sector Lekgotla. So what we're needing to do is build the capacity of teachers to support learners who are struggling with emotional and psychosocial issues. But we also need to be providing psychosocial support for the teachers who are experiencing their own emotional distress and who are expected to be supporting their learners. We need to strengthen and centralize the role of our school-based support teams within these collaborations, because it is through the SBSTs that referrals are made. We need to strengthen our partnerships between schools, universities, and districts. And we need to sharpen referral pathways between schools, districts, and NGOs. So one of the very practical strategies, for example, would be to introduce interactive activities, encourage expression through writing, speaking, drawing, visual aids, child-centered YouTubes, classroom discussions, so that learners start to become familiar with the language of self-expression and vulnerability. I think in closing, what I'd really like to say is the importance of good health and well-being represents the third goal for sustainable development. Given the absence of psychosocial support for the majority of our youth in South African schools, particularly during times of adversity, schools become critical sites to mainstream and promote mental health. We know from the work of Prof. Tomlinson and others that the foundations of mental well-being lie in healthy relationships, and that this is what young people learn in the schooling sector. Our children need to be centered, they need to thrive in order to become active, engaged members of our society. Colleagues, honourable members, silence is simply not an option. Survival is not enough. Thank you. Thanks very much. Over to you, Laurie.
Thanks. Honourable Wenger, I'm hoping I've got that right. I can't see your whole name in my little round circle in front of me. We're ready for questions in response to the last three presentations. So if you could lead in gathering questions from the members, that would be fantastic.
Thank you very much for those very informative and important presentations. I know certainly I have learned a lot and a lot to think about. I'm mindful of the time, so for this round, if members could try and keep their questions quite brief, I think we'll try and stick to 1 minute if possible, so that we can have all parties to be able to ask questions and then also in the answers. I just want, let me then start with you as usual with the DA. Are there any questions from the DA? If you just raise your hands. In the interim, if I could just ask, and I'll take some of the DA's time, with respect to well-being, that's obviously a topic that is very much front and centre for the Western Cape government You know, it's one of the focal points of the provincial government, and it's something that all the departments are focusing on. So I suppose my question is, how do we fit these things together from civil society, from academia, and into government's work? You know, is government adequately represented on some of the fora that you are working on? And then secondly, similarly for the Department of Education and Children and Teachers, how do we better integrate the work that civil society and academia are working on with the work of the Education Department? And I suppose the question I'm really asking in both respects is, how do we get to that whole of society approach where we can properly tackle some of these issues? Oh gosh, I've taken the whole minute. My apologies. We'll then move on to the ANC. Are there any questions from the ANC, please?
Thank you. Thank you, Chairperson. Am I audible?
Yes, please go ahead. You have 1 minute.
Thank you, Chair. Chair, mine is on, one of my questions is on violence injury. I just want to check on slide 3, what kind of psychosocial support is needed to support families suffering from poverty-related stresses, and whether these are available in the Western Cape? And then on mental health, Chairperson, what reasons were given for the dropout, and how many cases were due to bullying? And that was on slide 10. And then on the last schools issue of presentation, Chair, I just want to check what is the view regarding poor and ineffective psychosocial support to teachers and learners in schools. There is one social worker, psychologist per district. What recommendation can you give in this regard? Thank you, Chairperson.
Thank you very much. I think the EFF has left the meeting, so I'll move straight on to the Freedom Front Plus. Honourable Marais, any questions from you?
Yes, thank you so much, Honourable Chair. My question is basically the committee's brief, and what we're supposed to do is more a health issue than social educational issue. So it's very informative, the last 2 presentations, and it's very interesting. I will agree with the chair, but unless social department comes here and give their brief with relation to schooling, the education department, and with relation to social dynamics, like the teacher's role vis-a-vis the parental role in handling fragile family systems, and in the school context, I don't think we as a committee on COVID really are actually the best place where this should be presented, and we can ask intelligent questions on it. But it was very informative. I agree on that. I would just like to know that any discussions future would relate to COVID. It has many facets, many facets. We just heard it today. COVID is affecting every part of our interaction as a society. It's not going to be solved or resolved by one specific department. I would have liked to hear more about what we've heard here, but I would have liked to have heard a better response from the relevant departments, social services and education on these issues. But thank you so much. I can only say thank you for a well-presented case in defense of our children. Thank you.
Yeah.
No questions.
Thank you, Honourable Marie. I think Aljamar's also left the line, so I'll hand over to you, Ms. Lake. If I could ask if we could try and get through the responses in 10 minutes. I know that's a big ask, but I'm mindful of the time. Thank you.
I'm sure we can. If I could start with Shanaz and ask her to respond to the questions that relate to violence, that would be very helpful.
Okay, so I'll respond to Honourable Bin Voorgel that asked about psychosocial support interventions available in the Western Cape. As far as I am aware, one of the widest spread available interventions of psychosocial support would be parenting, and they delivered through different, NGOs as well as through the Department of Social Development. But I think it's really important that we understand that parenting on its own will not reduce the vulnerability of families. So I think what we are aware of, and I've done a review of interventions that's successful in reducing both violence against the intersections of violence against women and children, and I can make it available to the committee if you want to see it. But I think what's really critical that we've got to think about multi-component interventions, that a single strand intervention, given the context we live in, isn't sufficient to be reducing the magnitude of the problems that our families and children are experiencing. And therefore, for instance, we've got a large-scale poverty alleviation program in terms of our child support grant in South Africa that reaches large numbers of children, that's the most vulnerable. That's an easy win for us to be thinking about how do we reach those vulnerable families who are already accessing a child support grant, and thinking about the adding on components of psychosocial support that has the potential to be reaching the children that need it the most. So I really think that we should, as researchers, academics, be speaking to our government counterparts as well as NGOs to think about how we target our programs more effectively. So that would be my response. I agree that, and I would disagree with the Honourable Marie and saying that what we've spoken about in this session speaks to psychosocial support and focuses on, the missing departments would be social development. I do think mental health, violence, as well as educational outcomes are critical for us to consider, given the context of COVID. And we cannot think about children's experience in isolation, that it has a knock-on effect, and therefore thinking about children's exposure early on in life and the trajectory it has for later, for them as parents, for their own health, physical as well as mental health. It's critical that we consider it as a interrelated and we've got to see all these components as working together. Laurie, that's my response. Over to Mark or to Patty.
Thanks, Shanaz. Mark, do you want to step in?
Sure. Thanks, Laurie, and thanks for the questions. So I'll try, and there were 3 questions I thought I could respond to. So the first one about well-being and wellness, I think the Western Cape has been quite innovative and at the forefront with their Western Cape on wellness and seeing it in a broader concept of wellness, and I think that is incredibly important. I also want to say is who sits at the table, and I think here the idea, the example I used about roads as being so important. Actually, I stole that from Dr. Clutie, who before he became Chief of Health was at a meeting around mental health, the early years, and he came along to the meeting as a representative from health, and he brought somebody from the transport department the roads department, which is not the normal thing. People think, well, let's have social development, education, health. You know, they don't think about who should be brought to the table generally in terms of roads. And the idea was, let's think about roads as connectors, not simply as roads in a way of transporting goods. So I would suggest get every single person at the table. This is a whole of government as well as a whole of society approach. The example I gave on bullying, sorry, that was, I didn't have data for that question around bullying from South Africa. It's some data from the UK about many groups of children saying actually their life improved in lockdown, and they were very likely to be children who had good access to digital learning and all the things that go with that. But the issue is that for many children, it was a good thing, and it's likely that bullied children are in that group, but I don't have data for that. And then finally, in terms of psychologists and social workers, they are a really important part of the solution, but they will never be the solution. There will never be enough social workers and psychologists, and I think we need to acknowledge that. We need to think about how they can best be utilized so that their caseloads aren't so huge that they burn out. But we need to be better at prevention so that they don't have to get involved in the first place. We have to better utilize community health workers who are at the forefront, who I think can be trained, and we've shown that how they can be trained, for example, to do a screening tool for caregiver depression, for example. And where there's vulnerability, either refer to the health system, refer to somewhere else, or do an intervention themselves, but prevent things getting to the point where they need, you know, extended kind of intervention by professionals, because we will never have enough of those professionals. Thanks, Laurie.
Thanks, Mark. Handing over to Tembeka and Patty.
Thanks, Laurie. Before Tembi comes in, just a quick point on the whole of society approach. I think we need to acknowledge the role of the Western Cape Education Department during 2020 and 2021, and the efforts made to integrate different sectors of the society to look at how to address children who are out of school and how to look at schooling in the community during the lockdown periods. A huge amount of work was done and piloted by Haroon Mohammed and others, which integrated psychosocial components. But I'd like to, I'm aware of time, and I'd like to hand over to Tembeka, who might just be able to respond to one or two of the other questions. Thanks very much. Tembi, I think you're on mute.
Yes, thank you very much, Patty, and good morning to all honourable members and everybody on the call. I'm just going to respond to two of the questions, and one was, were there other reasons related to school dropout besides bullying? And of course there were, especially within the context in which we work in. And those reasons were really related to the home context a lot of the time. What's happening in the home context? You know, parents not having enough money to take children to school, the rotational system. You know, if you don't have to go to school on Monday and then you're going to go to school on Wednesday, the parents will redirect that money somewhere else. Or even the learner themselves, well, some of the things that they were speaking about was that sense of isolation and really having low moods a lot of the time during COVID. You don't really have the motivation to get up and go to school within that time. So obviously that practiced over time means that learners are less and less engaged with the school context. So it was a multitude of reasons of why learners, why there was such a high school dropout in learners, and really the essence of them were really related around that within the schools that we work in. And then the other, just very quick, the last question, which is about well-being and how we fit together government and the Department of Education and social workers in relation to that. In fact, the program that we run, which Patty was speaking about, the SRI, we do exactly that. So the idea is having very strong university school community partnerships. And the advantage of that is that firstly, the social workers, auxiliary social workers that have been spoken about can easier be part of the school environment. You can have trainees within the university being deployed or being doing their field practice in schools. And similarly, the partnerships that we then have with the Department of Education, and in our case, Metro East Education District, is that the social workers of those districts don't necessarily always have to be engaged in the schools that we would be currently working in, which is a large number. And it does eliminate, at the moment, we're working in 10 schools in Khayelitsha. So there's less of caseload within those schools. And similarly, with regards to some of the challenges that are raised, it's really, really important for us, having the child at the center, to have the community organizations being part of the school environment. And the benefit of that is that the school community in itself is aware of the resources that are available within their context related to mental health, because they're working so closely with the schools, and also the department being aware of the type of challenges that are actually rising up in schools because of the report backs they get from the work done by auxiliary social workers and social workers within the school context. So I just wanted to add those 2 points with response to some of the questions. Thank you very much.
Thank you. Thanks so much, Tembeka and Patty. And I just wanted to respond to the Honourable Minister from the Freedom Front. He raised a question about whether we were perhaps presenting these findings to the right portfolio committees. In my understanding, I had considered COVID-19 as a whole of society problem. So I had hoped, in a sense, that members of this committee would be able to raise these concerns with their engagements across a range of different government departments. I did want to raise the question, should we be presenting these findings to some of the other parliamentary portfolio committees to ensure that the issues are taken up there and that children are indeed put at the centre of all policies and programming? And the second question I wanted to ask was around budgets. There was a point raised earlier by one of the honourable ministers saying, to what extent are we considering children's needs in the budget allocations this year? Is that something that this portfolio committee could take forward? Because that would be a really powerful outcome of today's meeting.
Thank you very much, Ms. Lake. You'll be very reassured to know that there are no less than 10 standing committee chairpersons attending this meeting from both clusters in the social and environmental as well as budget committees. So you have presented to basically the chairs of the committees of the legislature. And so where relevant, those committee chairs can have further conversations and perhaps further presentations if you're available. So on that note, I'd like to thank you all very much for the very hard work that you've put into these advocacy briefs. We're very grateful for your time today and for sharing this information, which is so important. And I think the next is how can we help? How can we take this forward? And so we'll be then deliberating as committee members on some resolutions in order to take these forward. And I'm sure that we will be meeting again in the not too distant future. So thank you again very much, and for your very important work advocating for children's needs and children's rights. As said earlier, arguably one of the most important members of our society, our children. So thank you very much. That then concludes the briefing by the delegation today. If the committee members would just stay behind, please, for some deliberations. I'll just give it a few moments for our guests to exit the meeting. Members, as you know, our meeting is due to end at 11:30. I don't know if there are any resolutions or recommendations you'd like to table now, or in the interest of time, if we could table them in writing by Monday, 7th of March at 12 o'clock. If you could submit your resolutions in writing by Monday, 12 o'clock on 7th of March. Right, we do have 2 minutes. So thanks very much, Honourable Bartman. I look forward to receiving your resolutions, recommendations and requests for information. We have 2 documents to adopt quickly. We have 2 minutes. I will take them as read. So if we could quickly go through those. We have the minutes of the 1st of December, as well as the committee report for December 2021. Whichever comes up on the screen first, we will deal with.
Chair, can I address you?
Yes, you may.
I noticed that I am a guest here. I just want to make sure that is correct, which means then I will leave the meeting. I always thought I was a member of the school.
Yes, you are a full member. I don't know why you're saying you're a guest. You are a fully constituted member.
It stands here, if I go on participants, next to my name in brackets, they say guest.
I think it's because you're accessing from a different email, or it's the link that you've used. You're not, I don't think are you on your phone?
I'm on my laptop.
That's unusual, because if you're normally accessing from the main system, you will come up as Honourable P. Murray. And if you access from a different device, it will just put you as a guest. But it doesn't matter how you're accessing the meeting, you are in the meeting, and when you're in the meeting, you are a permanent member of this committee. So you have the rights of a permanent member, not to worry.
Then I would like to say, rather than say we won't formulate a resolution, can we at least agree that the resolutions must pertain to finding a common approach spanning over more than one committee to address the very issues of the children's welfare in the age of COVID. Children are affected by health issues, clinics, they're affected by issues concerning with education, budgetary controls. I don't know where the Children's Commissioner fits in the picture, why the Children's Commission isn't made part of this extended group that decides on the children's well-being. We could have formulated at least something like that to set the ball rolling, that the various committee chairmen get together and decide how they want to approach the issue, because it has multifacets.
Yes, you're quite correct. So please could you submit your resolution or recommendation in writing by Monday, 12 o'clock? I'm just mindful that we have standing committees, other standing committees that are taking place in 10 minutes. So can we quickly just adopt the draft minutes? Page 1. Please check attendance. Good. Page 2. And page 3. Honourable van der Westhuizen.
I propose that we adopt. There's just one thing. I think it's the African Christian Democratic Party, and not Christians, but essentially the minutes what we've discussed. Thank you.
Thank you. Can we then adopt with that amendment? We'll just have to fix that up, but yes.
Yeah, I second that, Chair.
Second, Chair.
Thank you very much. Minutes are then adopted. Then can we quickly beam up the report of December 2021? It's not terribly long and has been circulated to all members. You'll see it up on your screen in a second. Right, page 1 and 2 are the usual introduction and background. We can move through those because those are always the same. Then here we go, page 3, page 4, and page 5. Could I have a proposer or any edits?
I can propose. Thank you.
Thank you, Honourable Murray. Honourable Bartman.
Move to second.
Thank you very much. The committee report for December is then duly adopted. Thank you very much, members. We'll see you next on the 10th of March when we have a briefing from the Health Department. And then a reminder to please submit your recommendations and resolutions by Monday. Thank you all for your participation. Apologies, we've gone 3 minutes over time. This meeting is now adjourned. Thank you. Bye. Thank you.
Thank you, Chair. Bye.
Bye-bye.